The patient is a 72-year-old man.
Okay.
74-year-old man.
Okay.
He's a post-CAPG cardiac patient with a ECF around 50.
Oh, yes, sir.
So that you can speak. So we cannot give the pulse is around 60 or less, they are telling, and the BP is 100 by 60. So they can't give dexmedetomidine.
Yes, sir.
So I have to be very work with the team with the anesthetist.
Yes, sir.
So it will be a tricky case.
Yes, sir.
For GA, the patient was not fit. They didn't give the GA fitness also.
Yes, sir.
So I can't convert it to a GA also. They can't. So it's a bit tricky.
Yes, sir.
Let's pray for the best. But our good anesthetists have told to cooperate excellently with us.
Yes, sir. We are damn sure that you will do very well in local anesthesia.
What do you suspect is inside the sphenoid, sir?
The most common pathology is fungal.
Okay.
But I had encountered everything, even internal carotid aneurysm. The radiologist gave a report as a fungal ball in sphenoid, but I clinically diagnosed as an aneurysm, and the patient was upset with me. Why this doctor is giving wrong diagnosis, and they went to Apollo Hospital, where the ENT doctors opened and they probed the mass, and it was an aneurysm and blood, and they had to put 18 bottles of blood.
Okay.
So it can be anything.
PT or MRI.
So it can be anything, but fungal is a most common pathology. Okay. Yesterday we had a for us, but this is fungal ball. I feel let's go in and see what it is. But the pictures look like sometimes some pictures look like even a pituitary mass, but it is sphenoid mass. Where is the CT pictures? Are you getting the images? Hello?
Yes, sir.
So these are the MRI.
Yes, sir.
These are T1 images.
Yes, sir.
Where the CSF is black. This is T2 image where the CSF is white. Okay.
Right, sir. Yes.
This is a mass. Looks like a pituitary in the sphenoid. Okay. And the carotids are away. It's a hypotense lesion. Okay. And in T2 also it is hypotense. So it favors mostly of a fungal pathology. Okay. If it is acute sinusitis or chronic sinusitis or mucosal, then it will be bright in T2. Okay.
Can you show us the data section?
Can you show us the
The data.
sagittal?
Yeah.
Yes. Can you zoom this? Hello?
Yes, sir.
Can you get a picture?
Yes, yes, sir.
This is a sagittal picture. Zoom it. This is a cella. This is a sphenoid. You can get. This is again a T2 image. Okay? T2 also it is hypointense. So thereby it is showing that it could be a fungal. And then this is T1 image. You can see the mass. Okay? It can be even a tumor also. Let's see. If it's a tumor, I will take a biopsy and come out. If it is fungal, I will take it out. Let's go for the X-ray. I think X-ray. Sorry. CT coronal. There was a CT coronal. This is the CT coronal. Okay? The images are all small images. Hello, the images are very small images. Even very difficult for me to appreciate things. It's a pathology of the right sphenoid. Hello? These are all soft tissue windows. You can see heterodensity. Okay? That means it could be a fungal. Okay? And I don't want to explain everything. The septum, that's this, because you all know everything. Don't want to directly jump into the diagnosis. Okay? The septum is fairly straight, so I will not be doing anything for the septum. There is a large right sphenoid, which is heterodense, and a very small left sphenoid. I think that's only a mucosal thickening, not the disease. And I have to be very gentle at this point, because it is the anterior part only. It's a very small sphenoid. Okay. Posteriorly, it is fully communicating. Okay. Got it? Who is on the mic? Who is on the mic there? Okay. Yeah, we will now give you the complaints. Already I have given a short complaint about that. Doctor, your name? Durbi. Dr. Durbi is going to give the history.
So this patient has complained of headache since 5 days.
Only 5 days?
Only 5 days. When he comes to our hospital, there is only complaint of headache.
What is the gather endoscopy?
Sir, it's normal.
Okay, the patient is draped. It's a 74-year-old man. Now the pulse is around 64. BP is around 130, 73. Okay? Can you hear me? Hello?
Yeah, we can hear you.
Okay. Please interact. Then only I know that I am, the audio is in continuity. Can you adjust the table? Okay. Okay, the table is in a neutral position. I am making the head end elevated to the 30 degree. So the external camera. The table is not going up. So, Tulsi sir, maybe you can continue for some time.
Now it's going up.
Oh yeah, now it's going up. Yeah. You are yes. You can see what that. Some more. Okay, that's fine. Now you see the diagnostic endoscopy picture. Okay. This is the septum on the right side. Endoscopy?
એન્ડોસ્કોપી આપી દે
They are getting the endoscopy.
Endoscopy picture.
એન્ડોસ્કોપી નથી આવતું ત્યાં
Okay, you are getting?
આવી ગઈ
So this is the right nasal cavity, septum, inferior terminate, hardly any space. Okay. So we have to do a good decongestion under local anesthesia. See, this side also there is no space. So I will pack gently and repeatedly to get the space. So meanwhile, it will take some 3 minutes for repeated packing. So meanwhile, my endoscopy picture will be on. Dr. Tulsidas, you please discuss some points there. Please and you. Yes sir, okay.
Okay. Here. So,
Hello, OT. Hello, OT.
yeah, you ready?
How many minutes do you want more?
No, whenever you tell me, I'll stop.
Okay. I can.
I'll show one video.
Uh,
After maybe 5 minutes you can start.
but I am almost ready.
Okay, then start.
Okay. So, are you getting the entire picture? I am gently packing the nasal cavity repeatedly. Are you getting external picture or endo picture?
External picture.
So show the endoscopic picture and put the external picture in picture.
Now we get endoscopic.
External picture?
Endoscopic.
Okay. Give me back. So I pack very gently to get more working space. So the table is 30° elevated. I will show it once again. I am packing the left nasal cavity without injuring the mucosa. Very narrow nasal cavity on both the sides. It has a right sphenoidal mass, left a small sphenoid which is mucosa thickening. That's all. I don't want to do something around it. And it has a prominent septal body also. One more pack. Today again I have gotten very wonderful nursing team and a very cooperative, very beautiful, so not beautiful, beautifully cooperating anesthetic team. Sorry, there are 4 ladies not there in the anesthesia team. Sorry.
No, all are beautiful and beautifully human.
So I am in the middle of a luxurious cruising slowly. Okay. Now the external picture, please. So let's see. Mostly I will avoid. Let's see. Because sphenoid is quite down and there is no spur and high deviation will not cause something to me. So the external picture. Say many people hold the endoscopes differently. Some hold like this, some hold like this, some hold like this. Are you getting the picture by hand? Hello? Are you getting my hand?
Yeah. Hey, external there. External.
One second. Are you getting my hand? So, holding the camera, some hold it like this, some hold it like this, various way. Some hold it like this, but my way of teaching is this way. It's to be held like a flute, and I don't touch these 2 parts. One is the zoom, then another is focus. Some people when they touch it, when it is loose, the focus and zoom keeps on changing. And some when they hold it here, it keeps changing and the camera tilt occurs. So I always have it here and show the wrist. Yeah, it should be very like a flute. So there will not be, and it should be like this so that there will not be pressure on the hand and fingers. So this is my way. You follow whatever you like and everything. Okay, this is my way of teaching. I don't touch it here. Some touch like this, so they get a pain here. So it's all depends on. But this is my way, and my good friend Dr. Jani Ram also teaches this way. Okay, it's lovely. Okay. Now end of picture, please. Now let's see how much space we have harvested. BP, got it? Please. So now the pulse is around 70. BP is 137 by 75. Patient is a 75-year-old man. He can't sedate much. He has post-CABG. The septum is still bad. As Dr. Tulasi said, whether we have to correct the septum or not. So I think I will avoid that.
I think there is working space down below the high septal deviation, so that I may not require a septal correction. In this case, I can manage without a septal correction. Middle turbinate is little bulky. Anyway, I will be trimming the lower half of the middle turbinate. That's the choana. So I have enough working space, even though there is a slight septal spur also to that side, not gross enough to distract. there's a high septal deviation. If you are doing a DCR or a frontal sinus surgery, then you have to correct the septum. That's the middle meatus. Inspection of the middle meatus to rule out any pathology there. Now I am looking at the sphenoethmoidal recess. Still, we are not very confident of the diagnosis of this patient, even though MRI gives and CT picture looks like a fungal sinusitis. It's a 74-year-old man. It can be even a tumor or a malignancy. As a first step, I am giving the sphenopalatine block. Before that, I am giving the anti-ethmoidal nerve block because I will be doing the middle turbinate surgery. For middle turbinate and the frontal recess surgery, anti-ethmoidal nerve block is needed. You give few, maybe a half cc of local anesthetics. Here the ropivacaine was not available, so I am using 2% lignocaine with adrenaline. So now I have taken a 23 gauge spinal needle and the tip I have bent to an angle, and now I am giving the sphenopalatine block. There is a small camera tilt there. Please excuse me. You should not have a camera tilt at any time of the surgery. That's a sphenopalatine block, and you can see clearly a good blanching. Little more I am giving just underneath the mucosa. You need not go into the foramen, but underneath the mucosa it will spread. You can now appreciate the blanching very well. This is a unedited live surgical demonstration video. In between there is a voice didn't got recorded, so I am giving an voice now externally in the middle part from the 19th minute to 37 minute of the 51-minute video. This is a 51-minute video. So from 19 minute to 37 minute of the live demo, the voice was not recorded, so that I am now giving the voice externally. So after infiltration, I am packing the area with the 4% lignocaine with the adrenaline pack. So the video will be little lengthier because the Savlon and the setup, all these small things are not cut and removed, edited. So now I am giving the sphenopalatine block on the left side. Even though I am not going to do the surgery, sometimes if it required, I may have to. Moreover, I may be using the suction on the left side and everything. So it's better to anesthetize the whole both nasal cavity. See, it's the posterior part of the bulla I'm giving, because the exact sphenopalatine area is not, that's the area, it's not properly seen, so I am now giving little blindly. The infiltrated fluid will sweep there. Patients are very cooperative with a good sedation and a good infiltration, that is nerve blocks, that's blocks given. So we have got a good decongestion in spite of a very narrow nasal cavity on both the sides. The residents have trimmed the nasal vibrissae, which I don't do it routinely, but this will help me a lot. So any blood that trickles, you suck it from the choana. Never allow the blood to flow into the choana. If it flows, then swallow. Ask them to swallow it. I give little infiltration on the septum near to the sphenoid area, and maybe an infiltration on the anterior wall of the sphenoid also. That are not really needed, but definitely they will give an added cushion to the already given blocks. Now the first step, I am trimming the lower half of the middle ternate. So this is my way of doing medial approach surgery. Some prefer a lateral approach, some prefer an intermediate approach, and some medial. The medial is an easy, but it fails because of the middle ternate getting medialized and blocking the operated area and causing a synechia and failure. So I always remove the lower half of the middle ternate to prevent a failure or a scarring synechia at that area in future, and to have a clear view of the operated sphenoid sinus post-operatively. See, hardly any bleeding under local anesthesia. Patient is also very cooperative. In fact, I am trimming the middle ternate, still hardly any bleeding. Take care not to trim the whole ternate. Have a small attachment and just use don't avulse. It will cause tear of the septal branch of the sphenoid artery, and then never allow the ternate to slip into the choana, which had happened to few times in my previous patients. They swallow, they may spit. Sometimes it's dangerous if they aspirate. So little remnant area is there of the middle ternate, which I will take out with the shaver. Try to avoid injury to the septal branch of the sphenopalatine artery. I give an added infiltration at the root of the middle ternate. Actually, I have to give on the anterior face of the sphenoid sinus, that area exactly. Yes, that gives an added cushion and has a little decongestion effect also, so it hardly bleeds during the surgery. It's a luxury to do any nose and sinus surgery under local anesthesia. You can appreciate the field when I operate. Hardly there will be any bleeding, it will be very dry. Little blood that goes down, is suck it or ask the patient to swallow it. So again, keep a small pack on the infiltrated area to prevent any bleeding, and ask the patient to swallow as the patient was swallowing, and keep the patient at a moderate sedation so that whenever you ask them to swallow, they should swallow. They should not be over sedated. That is very, very important. So give 1 minute or so for the local pack to act to stop the bleeding from the infiltrated area, needle puncture area. A good decongestion has we have got, and patient is also very cooperative. Remember, it's a 74-year-old man, and you should not cause any pain that may aggravate his cardiac status. There should not be any pain shock, and do surgery very gently, meticulously, with care. Now I am using the straight blade of the shaver system to take out the remnant mucosa of the trimmed middle turbinate, so that we will have a look at the sphenoethmoidal recess area. Now the superior turbinate is coming into the view. This is the middle turbinate mucosa I am shaving off, and that's behind is the superior turbinate. Sometimes I may trim the lower half of the superior turbinate also, but I will try to preserve it because that has a lot of olfactory fibers. See, this is your superior turbinate. That has been a ethmoidal recess, little polypodal, and there is a little discharge was also there. That area also needs to be trimmed with the shaver. Be very gentle. If you come down too much, then you may injure the septal branch of the sphenoparietal artery. If you injure, then you again keep a pack for a few minutes. The bleeding will stop. Nothing to worry. So whenever there is little blood, you just pack with the pack which is dipped in a solution of 4% lignocaine and adrenaline in the ratio of 1:1. So good hemostatic effect, and now you can have a little better glimpse of the sphenoethmoidal recess. That's the sphenoidal ostia area, which is little polypodal. Easy way to identify is go close to the septum with a small elevator and just slip it into the os. There's a small cartilage elevator around 1.5 centimeters above the choana. Just slip it into the sphenoidal os and just press it open. See, the pus is coming. That's the beauty. Just press. You need not cut. Press it medially, laterally, inferiorly. The os becomes very big open. And for extra widening, you can use kerrison to take out the bone. But with pressure itself, medially, laterally, inferiorly, you can widen the os. How you saw it just now. I am sucking it out. See, with the pressure itself, see how big the opening is made without losing any mucosa. As far as possible, prevent mucosal damage, mucosal stripping, and everything that will prevent future fibrosis and future stenosis. See, full of fungal material within the sinus. Hardly any bleeding. You can appreciate the field very well. Now I am using a ring curette not to scrap, but to take materials for histopathological examination, fungal culture, KO smear. So again I am taking some more material for histopathological examination. After that, when you use the suction and everything, will not get material. So take enough materials for the analysis. Now I am using a straight suction to suck the material. Now the live video audio will be available, and it will take you to the end.
Happy?
How much you wide the ostium in this case?
Huh?
How much you wide ostium in this case? Will you not remove the terminating?
Maxillary and sphenoid ostia opening, there is no rule and there is no hard and fast rules. How much that disease, how much you want to remove the disease depends on that, and depends on the size of the sinus. Okay?
Will you not remove the part of the superior terminating in this case?
Yeah, you are asking me to make the patient bleed. Keeping on asking me, troubling me to injure the septal branch of the sphenoid artery that runs here. So if I were there, it will bleed, but I can. But if you want that, what you should do is give me the elevator. I will show you the techniques, everything I am. Give me the elevator. Sisters are sleeping. They are wonderful sisters. Yesterday I booked flight tickets for them to Chennai, so they are very relaxed. See, hello, you just take the mucosa.
Mucosa down.
Yeah, down, okay.
Yes. To prevent
Now give me the Kerrison, give me my Kerrison.
to prevent injury to the rectal branch.
Right, still sometimes it bleeds, okay, no problem. Just right. Give me the Kerrison down. Down. No, I don't like it. I have it. It is near to my dustbin. I have nearly 10 lessons. I have nearly 1C of the instruments. My wife knows diamonds and gold. She asked to buy gold diamonds, so I buy everything for instruments. So she is very upset. Okay, little more you have taken, some more I will take. That's the technique, secrets. These are all secrets. But everything will be in my YouTube videos. No hidden things. All for teaching instant. Give me the Kerrison once again. So I will be finishing the show in another 10 to 15 minutes. Please get ready. The next case for Dr. Tulasidas, that is septorhinoplasty. So she is snoring. The patient is loudly snoring, man. So you should get you ready. That's over. Put you over. Slow down. Okay. You should have slowed down, madam. You gave a lot. Now he is snoring. Okay. Okay, in GA you can fast clean these things, fish. In local you have to be little gentle, okay? I will take some time, okay? So it may be look a little boorish for you, but you have to be gentle under local. But I will finish in 10 minutes. Give me my whatever thing you have to give. That one drink you have to be clean plaster. Yes, that's how it is. So here after the job is nothing great. Everybody can do that. Okay? It's just a remote job. Don't scrap the mucosa. Preserve all the mucosa. And I will teach you the wet mopping technique. Wet mopping technique. You can't wash. In olden days, when I was young kid and everything, we have cement rooms and everything. Floor. He was snoring, that's why. Okay, the patient is snored, so the saturation went up to 88. So I told anesthetic nothing to worry, wake him up, that's all. Because extra dose of scotch has gone in. Say this is for their culture or something. My sister, you are sleeping. You should look at me. This patient should look at me. Yes. She was turning to her side. She wants the patient to look at her. So always the patient should look at you and you should not have a camera chill. See, there is no questions, nothing. Are they sleeping? Are they bored down with my surgery? I don't know what's happening there.
All are right, sir.
Huh?
Eagerly watching today.
Watching.
Yeah, eagerly.
So first time watching a live screener under the LA. Yeah. This is Sella. Okay. Do you want to open and show? Do you want to open and show? Under local. Yes, they want to. So set it drill.
All will send you video after operating local, sir. All are saying like that.
Call Rajkot. Okay. So somebody is asking a question. I am past 7-8 years using curve setters. I am using ropivacaine for infiltration. But here I asked, they didn't give me first. They didn't give me. Okay. So I am using a 2% dilacin with adrenaline in the ratio of 1:40,000. What's the advantage of ropivacaine? Ropo extraction goes for 4 to 5 hours. Dilacin only around with adrenaline 1.5 to 2 hours. Sir, I have published an article on that. You please go to my. You can get the article from net for $33. Hey. I will give Jangri. Jangri is coming. He is sleeping, so I am telling Jangri so that he will wake up.
You now use mop, sir?
Pardon me?
You now use mop.
No, we have stopped the sedation. Little went more. So a little he is sleeping, so we will wake it up. And he is in a waking condition only. I will never allow my anesthetist to oversedate. That's the first agreement between me and my anesthetist. like a wedding agreement, first agreement.
In your local anesthetic,
A lot of noise. Please come again.
sir, in your local anesthesia surgery, always anesthetic is standby?
Yesterday I put the slide. You didn't watch the slide. I am the Arjuna on the chariot. They are the Krishna. Without Krishna, the chariot can't.
Very good.
But 8 years before, not 8 years, some 15 years back, for 7-8 years, I was operating only without anesthetic for all local cases. My earlier days, after my post-graduation. But after that, I found that it is stupidity. So I applied everything. I can't wash, but I will show the wet mopping technique. Okay, give me the wrong one. I will mop it up. So I told you, the olden days we wash the floor, longer one, with water, wash that floor. Now people are living in apartments and everything. They can't wash the floor. So this is my technique, Ahilasamy's technique of wet mopping. We mop the floor nowadays. And now that has also gone, and then now people are using vacuum cleaners.
So many things on the name of Ahilasamy.
Ahilasamy's wet mopping technique.
Wet mopping technique, instruments, few instruments are
Yes.
there.
Yeah, we have to put our names, man. Why these white people's name only is coming?
Gujarat dry state technique for
Yeah.
Ahilasamy.
Yes, yeah. We have this technique as Gujarat dry technique. So hardly 1 or 2 ml loss. Am I correct?
Yes.
Hardly 1 or 2 ml. That's why I told anesthetists don't give any IV fluids. So still they are giving in the 50 ml pack, mini pack. They wanted to give, I told them you should not give any fluids because it's a dry surgery, but still they are giving 50 ml packs. So this is wet mopping. Wet mopping, and don't traumatize the mucosa. If the mucosa is everything, even if you leave it little bit stick, all the sticking yellow things are coming out. See, yellow things are coming out, and small bits will this mucosa will come out. And I put some itraconazole, madam, for yesterday's case and this case, itraconazole 100 milligram BD for a week.
For a week also.
Okay, so it's fine.
Yes.
Yes, very nice, sir, very nice.
For sticking things, we can leave it. So, do you want me to pack?
Yeah.
Do you want me to
Yes,
pack?
we will send.
Let's do this. If you want, I can do it on. See, that's a very small sinus.
Put small pet.
See, no, you should not put the pad, man.
Oh.
You should learn it from the gynecologist.
Okay, so.
The gynecologist never use it pads after DHC. So I keep cotton ball here, like a pad. Okay?
What are the other post-op management, sir? Other medicines?
See, hardly any bleeding. Less than 1 ml. Dry state, is it dry?
Yes.
It is dry.
Yes.
Okay. Ma'am wants to see the other side also. Even though there is no disease, it cannot be bilateral also. You will what are you? The simple.
What are the post-op medicines, sir?
Post-op is a routine nasal douche from the second post-operative day onwards.
Nasal douche of what?
Saline with soda bicarb or plain saline water nonsense.
No any steroid?
Steroid for this disease no. For for us, yes. I am not on the douche. I am not a very big favorite, but I use intranasal itraconazole. So madam wants to see the other sphenoid. I said it's normal this thing only mucosal thickening. Soda elevator. So let's see the ortho area. If there is there is hardly any discharge or anything, only the mucus. So there is the CT also only the mucus thickening, and in MRI it was clearly seen it's only on the right side. So there is nothing. Okay. So I don't want to do unnecessary things. I am a man who doesn't do unnecessary things. Give me the elevator. I little fractured the middle terminate. You know, we didn't do any surgery. It has gone little lateral. Okay. So I will little push it back. Okay. Be careful. But you know I didn't do any surgery. Okay. So it's kadam. So hardly any trickle. Totally Gujarat.
Very nice demonstration, sir.
Thank you.
Happy.
So at the start of the surgery, we all anesthetists, everybody was nervous. The surgery, the procedure doesn't want to post it because the patient didn't get a fitness. So no visa and everything. I told no need for any passport or visa for my surgeries. You please post it. I will do it.
Thank you so much.
Yes.
Thank you, thank you, thank you.
Thank you, sir.
Doctor,
Nice one.
hope I have shown past 2 days some. See, hello, hello, auditorium.
Yes, sir.
See the patient. See the patient. See me. See, bolo, whatever is it.
દાદા જીવર કાઢો.
Are you comfortable?
તમને કઈ તકલીફ નથી ને દાદા?
Any pain?
આખું નામ બોલો. તમને કઈ દુખાવો થાય છે? બરાબર. કઈ દુખાવો થાય છે એમ કે?
Hello? Hello? Are you, did you say the external picture?
Yes.
Patient speaking and everything?
Yes, sir.
So he is ready to sit.
બધા બેઠા રહેવા.
See? Sir, give us this. Okay? Okay? You saw the picture? Hello? Yes, okay. He's fine. So we will shift him to the room and then after 3-4 hours later he can be discharged.
Very nice.
It's a real.